Good afternoon to one and all. And I'm Dr. Prateebha Devi Nivean, and I'm here to present a few challenging cases in ocular tumors which I had faced in my practice, and I'll give few pearls which we should follow it in our regular practice. So this is a 55-year-old male who came to us with gradual progressive proptosis in his left eye over the duration of 5 years. He had a history of RTA 6 years back, and he lost his vision in his right eye. Since he was one-eyed, he was neglecting treatment, and when he started developing a defective vision in his left eye, he wanted to have a treatment. So he had no perception of light in the right eye, and he had a vision of 6/18 in the left eye with an eccentric proptosis and lag of Tumors with exposure keratopathy and a disc edema in the left eye. The apparently good eye had no vision. This was his imaging picture. So the scans shows gross proptosis with mass lesion involving almost the entire left orbit, encasing and molding the globe without causing any indentation of the globe. So this is very pathognomonic. The molding of the globe and no indentation is very pathognomonic of lymphoma. So in any case, we have to do get the diagnosis by doing a biopsy and then doing a histopathology and immunohistochemistry. But doing a biopsy in a patient like this is a little tricky because the patient already had a very tense globe, and a biopsy could cause bleeding inside and intra-op or post-op, causing no perception of light in his seeing eye as well. And on careful examination and as a blessing in disguise, this man in his right eye had a similar conjunctival lesion in his lower subconjunctival space, the typical salmon fish appearance or the fish flesh appearance suggestive of lymphoma. So we took a biopsy from the right eye, and immunohistochemistry and histopathology was confirmed, and the management was done, and this is the patient after radiation. Similarly, this is another gentleman who came to us with complaints of left lower eyelid swelling with a mild proptosis in left eye. So this patient, the CT and MRI scans were suggestive of lymphoma. The typical mass lesion caused molding the globe without any indentation. So we did an incision biopsy. We sent for histopathology, immunohistochemistry, confirmed it to be lymphoma, and we gave radiation, and the patient was like this post-op. In 2023, he again came to us with a right eye lower lid swelling. So I reviewed back the scans which we did earlier, and I noticed that there was a subtle small lesion in the right eye even during that period. Probably that was missed, or the lesion was so insignificant we could not have picked it up. So this made me think that so we should understand that in any orbital case we should also look into the other eye. There might be a lesion similar or might be subtle compared to the other eye. And the reason in lymphoma for the bilaterality is the MALT-associated lymphomas are said to have bilateral lesion because of the homing effect. The cells adhere to the epithelial surfaces. So the bilaterality is more common in MALT-associated lymphoma. This gentleman came with a swelling in the right eye upper lid. So as a general ophthalmologist, one should carefully look at the swelling. When to decide when to do an incision biopsy or when to do an excision biopsy with a margin clearance. So loss of lashes and lid margin architecture alteration are the two main things which we should look for deciding on the treatment. And since there were loss of lashes and lid margin was altered, I planned to do a excision biopsy with margin clearance, and the patient came again for a review in 2021. I found that there was a small nodule seen again in the upper lid. So again I had advised him an excision biopsy with margin clearance. I did an excision biopsy. I do not have a frozen section, but the COVID lockdown came and the patient was lost to follow up. Again he came back sometime later with a keratinized lid with conjunctival congestion and pain. So we planned again to do a lid margin excision with margin clearance, and the patient was like this. The patient is due for a lid reconstruction. So the pearl here is these cases are not a single line of management. That doesn't stop with a single treatment. The patient has to be explained about the nature of the disease, stance of recurrence, and lifelong follow-up is needed. This is yet another case where there was a left diffuse thickening of the left eye upper lid. There were loss of lashes. The lid margin architecture was completely altered. Clinically, this patient is definitely suspected to have a malignancy. Yes, the histopathology confirmed it to be a squamous cell carcinoma. So this patient underwent an excision biopsy with 5 mm margin clearance, and then I did a lid reconstruction with the buccal mucosal graft and a forehead flap, and the patient was like this. But unfortunately, the patient came back again last year with a recurrent, very aggressive swelling like this. So the pearl here from this case is always involve colleagues in management of such cases, because there can be medico-legal issues as well. And this patient actually finally ended up with exentration, so have a tumor board meeting for decision making. I do a freelancing of oculoplasty surgery. So one fine morning when I went to do a surgery in another hospital, there was a case of a 35-year-old female who had painful blind eye, and she wanted cosmetic correction. So I said, it's just a normal case, let's go ahead with an evisceration and ball implant. So on table, this was a surprise. There was a firm mass kind of lesion in the while scooping out the uveal tissue. So we did a histopathology. Luckily, that was not a malignant lesion, and oncologist's opinion was also obtained, and we are following up the patient. But the pearl here is never take up an evisceration before doing a B scan. Might it be a own practice or might it be a freelancing practice? In suspicious cases, we should not hesitate to do even an MRI scan. This is another child who had an eccentric proptosis, who gave prominence of eye on and off, aggravated with respiratory infection, and this child had acute decrease in vision, came with an acute decrease in vision. So her vision was hand movements, and there was an RAPD with a hyperemic disc. So her scans, this was her scans, and there was cystic lesion occupying the entire orbit, sandwiching the optic nerve, causing the compression of optic nerve and hyperemic disc. So this child had a with the history and the findings, this child was said to have lymphangioma with bleed and optic nerve compromise. So we did, and we gave IV steroids, and then we took her up for ultrasound guided aspiration of cystic fluid and gave bleomycin to collapse the cyst. So the pearl here is always follow less invasive techniques over complicated or in more invasive techniques. This is my last case, and this is a young girl who came with just a small lesion, with just I did an excision biopsy, and it came out as xanthogranuloma. And since it was a very rare presentation, we published it in 2017, and unfortunately in 2022 she came back with multiple swellings like this. And not all xanthogranulomas present like this, so we might get swellings like that as well. So all yellow lesions are not xanthelasma, and HPE is definitely mandatory, and chances of recurrence has to be explained to patients, and in recurrence we can give steroids in those cases. So to conclude, orbit and oculoplasty is a Pandora's box. Every day is a learning. We learn from patients, but we should keep the basics in mind. Thank you, AOS, for the opportunity.
Thank you so much, ma'am. That was wonderful collection of cases. So we can move on to the next speaker. Sir, you want to take
one simple question, that what after the excision you follow which technique, for cutler bird or tensile flap for reconstruction?
For which case, sir?
For reconstruction of your tumor.
Which case?
For the lid tumor with present as something like
based on the size, sir.
Okay.
So if it is just a small defect, we will first try for a direct apposition.
Okay.
And in older people, we get a lot of lax skin, so direct apposition will help. If it is in younger patients, we might not have lax skin, so we have to do a canthotomy, cantholysis, or do a tensils to get some skin for us to do a direct reconstruction.
Okay.
If the defect is large, then we prefer
in your case, which technique you follow?
I put a graft for that man with sebaceous with squamous cell carcinoma. I put a graft for posterior lamella. I took the forehead flap for the anterior lamella.
Okay, but because I like to know that suppose you get an recurrence very frequently, will you suggest any radiotherapy for such type of patients? Radiations?
Radiation, yes. For lymphoma, I had suggested. For sebaceous gland lymphoma, I discussed with the oncologist, and then we take up.
If there is any skip lesions and all, we can advise them to go for radiation.
Sir, as a neoadjuvant chemotherapy, I had tried, sir, as a primary treatment, but not radiation as a primary treatment. I don't know. You can give your inputs on that as well.
Right, good. Thank you, madam. And moreover, that xanthelasma, as you told, no. Now the presentation of xanthelasma is not simple as xanthelasma. It's presented in various forms. Like as you told us, something like a granuloma formations. So it's very difficult to treat such type of patients also. Right. Thank you, ma'am. Thank you for the presentation.